that I particularly managed in our emergency department. And this was a 67-year-old gentleman. He's a driver by profession and had a background history of hypertension. And he was on unknown antihypertensives for the period that he has been hypertensive. He was referred from Peripheral Regional Referral to Mulago National Referral Hospital, where I work, or where I'm doing my residency. And when he presented to us, the reason for referral was the worsening dysphagia, which had been there for 2 days, and also he had worsening shortness of breath, which had been there for a week, and for which he was being managed in the facility that referred him to us. I don't know at this point, could there be any information that might be helpful to you that you would want to know as the audience before we can progress with the case? That was the patient that we received in our emergency department. I know that, yeah, from just the presentation, could anything strike you about this patient?
Yes, please. This is Richard.
Yes, Richard,
Maybe
go
if
ahead.
if you could also help us know which antihypertensive he was having. Thank you.
Thank you, Richard. He was on unknown antihypertensive, like I did say. We couldn't establish exactly what antihypertensive the patient was taking.
Okay, thank you. Thank you.
Thank you, Richard, for asking that. I think that was an important question. Anyone else would want to maybe ask, know anything about this patient? Is there any information that you think might be helpful in navigating and finding out what exactly could be happening to this patient? So like Dr. Daniel said, it's going to be an engaging session. So anytime I turn out to the audience, you can feel free to ask whatever queries that you might be having. That might be helpful in you figuring out what exactly is happening to the patient and how you're going, the information that might be helpful in managing the patient. All right, in the event that I do not have any other, yes,
Jimmy,
go ahead.
there's a question on the chat.
Okay.
Why was the patient referred? What was the reason for referral?
So what we got to establish is that this 67-year-old gentleman walked to the referring center. And initially, he had just complaint of palpitation and also lightheadedness. And later, the doctor that received him in that facility did not thought it wise that the patient should remain in the hospital and should not go back home. And the patient was told to call his caretakers to come and join him in the hospital because he cannot be, it's not safe for him to go back home for some reason. Yeah. So after getting admitted in that facility, 2 days later, it is told that the patient develops dysphagia, and then he also developed difficulty in breathing after the admission for some reason. Is that helpful? Could that help with the question that was asked in the chat?
Yep.
Okay, thank you. All right. There are no any other questions. I'm going to progress with the case. Our expert of the evening is Dr. Kenneth Bagonza. Dr. Kenneth, would you want to know any more information about this patient? What are your thoughts about this patient at this point?
Thank you, Jimmy. Maybe I did not pick up on it. What did you say was the reason why he presented to the referral site in the first place?
So we know that the patient has a background history of hypertension, and for that he was taking some unknown antihypertensives, which the patient wasn't able to tell us because he wasn't able to speak, and the caretaker that he came along with did not know the name of the medicines. But one thing we got to establish is that he went to the referring center because of palpitations, and also he was feeling lightheaded and also weak. So he just woke up on a particular morning. He was very weak, lightheaded, and he had a lot of palpitations, and it triggered him to go and see a health worker.
All right, thank you very much. So, so just from that presentation, I know we're looking at a patient who has altered mental status. So, when it's not mentioned, sometimes it throws you off a little bit. But the number of potential causes of his presentation, but given the background history of hypertension and palpitations, then on my list of differentials at the top there are cardiac causes. And when I was just going through his presenting complaints, which were dysphagia and shortness of breath, and I'm looking back at him having palpitations, then I'm concerned about him. My main differential is that he probably has a valvular lesion, and by this I mean the mitral valve, and he might be having left atrial enlargement that is compressing on his esophagus and giving him a sensation of dysphagia. But I also know that when patients have arrhythmias, especially the tachyarrhythmias, some of them will have dysphagia as a presentation. So I'm thinking cardiac, and maybe as we go along and get more history and more information, then we'll be able to expand on our list of differentials.
Okay, thank you, Dr. Kenneth. I think you think it's helpful in approaching this patient at this point. Should I continue?
Yeah, I think we can proceed.
All right. So this was his primary survey at the time when we received him in the emergency department. His airway was threatened because he had a reduced level of consciousness. In fact, his GCS was 11 out of 15. And he had reduced, generally he had reduced breath sounds in all lung fields. He also had bilateral crepitations, and he had bronchi throughout his lung fields. And in circulation, the patient had a fast heart rate. He had a pulse rate of 150 beats per minute. It was strong. And he also had a distended jugular vein. And on listening, on auscultating, the valvular areas, he had S1, S2, and we couldn't elicit any murmurs on auscultation. In his disability, he looked lethargic. His GCS was 11, like I said earlier, with eye opening of 3, verbal of 4, and he had a motor of 4. His neck was soft, and his upper limbs, in the arm, he had a power of 3 out of 5, and on the leg, he had a power of 4 out of 5. We realized that his right upper limb and right lower limb were all normal power, normal tone. And then we progressed to also check for exposure. It was normothermic. Unfortunately, we didn't have a thermometer actually to establish the exact temperature. But one thing for sure is that it was normothermic. He had an NG tube in situ, and he also had a urinary catheter in situ. We couldn't see any rashes. We couldn't see any injury at that time when we did our primary survey. Dr. Kenneth, any additional thoughts at this point, looking at how the primary survey was like?
Jimmy, just hold on, Dr. Kenneth.
Yeah, we should get the audience's thoughts maybe.
Yeah.
Okay, the audience, anyone in the audience, anything that comes to mind at this point before we can call in our experts?
Yes, Jimmy. Hello.
Hello, this is Rachel.
Yes. So, Jimmy, can you please tell us about the character of the pulse rate? How was the character? Was it regular? Was it irregular? Because my thought is just, I'm thinking maybe something like cardiac that caused something, neurologic. Maybe this patient had an arrhythmia, maybe, and as a result of it, maybe got an emboli. Particularly, I'm thinking of AFib because I'm seeing the pulse rate was more than normal, was 150, and maybe got an emboli, threw it up, and then maybe got a stroke. That's why, because when you talked about disability, it has some weakness on one side. So, and then you didn't tell us about the pupil. We don't know whether they were equal or unequal. Also in disability, we didn't also get the glucose level for the patient. So we need more clarity on that, Jim.
Okay, thank you.
Jimmy,
Thank
maybe
you.
before you could note them down and then everyone asks and you answer. Like we need three more questions when you answer at once. Because in the chat, I can see members are asking from breathing, what was the respiratory rate? What was the SpO2? Because the cardinal presentation was a worsening difficulty in breathing. Then also for circulation, there was no BP, and then of course the character of the pulse. Yes. Any other questions from the audience? Okay, just one more RBS. So in disability, it is not mentioned. So Jimmy, you could go ahead if you have the response to that.
Thank you, Dr. Daniel, and thank you, Rachel, and the rest of the audience that have asked those questions. I think those are very good calls. So on circulation, I did mention that the patient in his record, it was documented that he had his pulse was strong. However, about the regularity, for some reason, I didn't find that documented. Yes, and then about the blood pressure, unfortunately, we did not have a BP curve at our disposal at that time, but it was later on taken. And we got to realize that the patient had a blood pressure of 126 over 73. When it comes to disability, we had glucometer, but we did not have the strips, and we weren't able really to do that. His son was quite young and wasn't able to finance most of the things, but yeah, we weren't able to really establish the GCS. The pupils were equal and reactive to light, that's for sure. Yeah, I think that is it. Is there any that I have not responded to, Dr. Daniel? I think.
So far, so good. Someone was just seeking for clarification. What did you mean by the term threatened? Did you want to also mean that the airway was at risk? Jimmy?
Thank you. One thing we know is that if a patient, yes, can you hear me?
Yes, please, go ahead.
Can you hear me, Daniel? Yeah. One thing we know is that if someone has reduced level of consciousness, that means that they're not going to be able to control their tongue. So they could potentially have a tongue fall that, and when the tongue falls backward, it can obstruct their breathing. And also for this patient in particular, also had some bit of secretion. In his, you would hear him gargling as he tries to breathe. Yeah, so what I meant by threatened airway was because of the risk of the tongue falling back and blocking his airway.
Okay, thank you, Jimmy. We could proceed then to the expert.
Thanks for those who
All right,
contributed.
Dr. Kenneth.
Yeah, thanks. I hope I'm audible.
Yes, we can hear you.
Yeah, a number of very interesting questions have been raised, I think, especially surrounding the initial assessment. And there's some excellent questions, which I'm just going to re-echo just to emphasize the importance. So one was a question from Rachel, which is essentially, okay, this patient is tachycardic, but is this regular or is it irregular? And thinking about it in the context of something like atrial fibrillation, with the risk of having thrombi, and then a clot can break off and then, go and cause a stroke, and your patient presents with altered mental status. So that's an excellent question. So it's always good to check. So if someone is tachycardic, we find out what rhythm are we dealing with. Then there was the very important point which Jimmy has labored to explain, but also somebody in the chat asked and said, what do you mean by a compromised airway or an at-risk airway? And that has been explained by Jimmy. What I wanted to just highlight is that, when a patient presents with altered mental status, of course, as a clinician, you're concerned about two things as you try to figure out. One, you're trying to find out why does a patient have altered mental status, but number two, you're trying to tease out the complications of having an altered mental status and dealing with them. So one of the complications we've looked at so far is the fact that patients with AMS have a compromised airway, so we have to have a plan on how we're going to manage that airway. And then one of the quick causes of altered mental status that we can quickly correct is hypoglycemia. So when you have a patient with AMS, it's always good to check a blood sugar whenever you can. And from a practice point of view, because I know it sounds a bit obvious, but not a lot of places will have a glucometer that is readily available. So it's all, if you're not able to check a glucose and you've asked, for example, in your ample history, and the patient's last meal was a while ago, then you can err on the side of caution and give the patient some dextrose and see if this improves their level of consciousness. Now, going to the initial assessment findings, there are some things there that sort of piqued my interest, and I have some extra questions I would like to ask about them. Number one is this patient had obviously the presenting complaint was dysphagia and shortness of breath. And my assumption would be that the altered mental status was an assessment finding. So my question, what I would ask the caretaker would be, at what point between presenting to the hospital from which they were referred to presenting to my hospital, at what point did their mentation change? And then I also noted that the patient had an nasogastric tube, but on respiratory exam, they had bilateral crepitations and rhonchi. So these can be, so the crepitations and rhonchi can be because of a couple of factors, but the ones that stand out for me, number one is, first and foremost, did this patient aspirate? Okay, did they vomit and aspirate because they had an altered level of consciousness, because they had lost the ability to protect their airway? So then the question for me would be, did the patient vomit with an altered level of consciousness? Number two, did you attempt to feed the patient? And this happens more often than we think. Did the family attempt to feed the patient when they were altered? And then the other question would be, at what point was the NG tube inserted? Was this inserted before the patient altered or after the patient altered? Because sometimes the tube might have dislodged, the family attempts to feed, or the health workers attempt to feed, and then they end up pushing contents into the lungs. So that's something to look into, aspiration pneumonitis. The other potential cause of these crepitations, especially basal crepitations, would be heart failure. And when I tie this together with the fact that the patient was tachycardic and had distended jugular veins with crepitations, then I'm thinking that this patient has heart failure, and this might be heart failure that is propagated by a potential arrhythmia, or there's something else. And then the other thing is, I would like to know the other cause of heart failure, of course, would be if you have a patient who already has underlying cardiac issues, and then you give them a large volume of fluid. So I would like to know how much fluid the referring facility give. I'd also like to know what medications were given from the referring facility, so that I can try and tease out why this patient has these bilateral crepitations. And then, of course, the other one is hypoxia, because if the patient is hypoxic and has been hypoxic without any intervention, then there's a risk of them having hypoxic brain injury, and that can contribute to their altered level of consciousness. Yeah, those are my thoughts up to this point in time. Thank you.
Thank you, Dr. Kenneth. Yes, the NG Tube, just to respond to a few of the comments that you've made about the NG Tube. Actually, this patient came from the referring center without NG Tube, but apparently they had attempted to feed him from the referring center, and they got to realize that he was struggling to swallow, and he was coughing on every attempt to feed. So he came to us at the point when they tried to feed him, and they got to realize that he was coughing, and then later developed worsening difficulty in breathing because of that attempt to feed him. And that's why the biggest challenge that led to his referral was, why is the patient not able to feed at all? Why is his mental status reducing every afternoon? He actually walked alone to the center that referred him to us. He walked that he had at that point was that he feels his heartbeat was so fast, and also he felt a bit lightheaded, and he was weak. So that concerned him and led him to going to that facility. All right, and also before also presenting, you also had some bilateral lower limb edema for that, just to make mention of. All right, so we are going to progress to his sample history. So getting to know exactly what could have led to the situation that the patient is in. So we use a called sample, where S is standing for signs and symptoms. And in his signs and symptoms, like we said, he presented with worsening dysphagia, and also worsening shortness of breath that was preceded by palpitation, lightheadedness, and generalized body weakness. A stands for allergies, and the allergy status was a known. He didn't report any known food or drug allergies. And medication history, we know that he was taking some unknown antihypertensive, but he was also started on Lasix, spironolactone, and rivaroxaban from the referring center. That was after he had developed the dysphagia, then the noisy breathing. And then for the past medical history, we know that our patient has a background history of hypertension, and he did not have any other chronic illness that was known to him. His last meal, at the point when we reviewed him, he was being fed using NG Tube in the emergency department. However, like I said, they had tried to feed him orally, just giving him what to eat so that he can swallow by himself, and they got to realize that he wasn't able to swallow anymore for some reason. The veins around was basically really deteriorating level of consciousness. So we requested for a complete blood count, which revealed a white blood cell count of 7.29. His neutrophil was 6.4371. He had a platelet count of 3.46, and his HB was 12.4. So the CBC generally was unremarkable. I've left out some of the parameters, but they were all unremarkable. And the renal function test showed us a creatinine of 357 with a blood urea nitrogen of 24.6. He had a sodium level at 148. Potassium was 3.89, and his GFR was at 18. And at that point, we thought, could he have developed also AKI, or did he actually have a CKD? That wasn't, AKI is acute kidney injury, and CKD is chronic kidney injury. So this was like the first time we are getting to do his renal function test. So we couldn't establish whether it was acute or chronic, but most likely with this GFR, we actually thought it could be more of a CKD, but we weren't able to conclusively make that based on the fact that this was like the preliminary renal function test that we are doing. And on his liver function test, he had a reduced hypoalbuminemia of 30.5, and his ALT was at 11, AST was 13. He had a bilirubin level of 3.2 and total protein of 61.8. His coagulation profile was PT was 20.2, PTI-NARA was 1.6, and he had a elevated D-dimer of 20.19. His HIV test was negative. His ECG, we are going to see in the next slide. We also did a brain CT scan, which I've also included in this presentation, and we requested also for a cardiac echo, which we weren't able to do because the patient didn't have money to do it. So this was how his EKG was looking. I don't know whether someone would bother to take us through the interpretation of this. Any person in the audience? Yes, Juliet. You can go ahead and take us through the interpretation if you would, if you'd wish to. Alex, would you want to do that? All right, in the event that no one in the audience is ready to take us through, maybe I will request our expert if you can just take us through a brief interpretation of this EKG, because it's going to help us make a decision on how to manage this patient.
I see there's somebody in the chat who's attempting to sort of talk about it, so maybe we can encourage them to just share their thoughts with us.
Hello.
Yes, Dr. Priska.
Have the intervals and the rate. Not seeing the intervals.
Okay, this is Bernard message from us. I wanted to just highlight.
All right, let's just hang in there a bit. There is interaction.
Bernard, I'm struggling
we
to
start with the students before we go to the physician. So Bernard's hand was up, and Bernard, yes, you have now the platform to take over from here. Yes, Bernard. Bernard, you can unmute and give your answer. Okay, seems Bernard has logged out. Rachel, your hand was also up.
Yeah, I was saying we don't have the intervals, but if I'm to use the Bizimu strip, of what I'm seeing, the rate is I think the rate is greater than 150, and I'm not seeing the baseline. I cannot see the P waves in this in the rhythm strip, and I'm seeing an irregular rhythm. So my take here is patient has a AFib because we have a narrow QRS complex. So that tells me that yeah, it's AFib. That's my take. Though we don't have other parameters on this ECG.
Okay, AFib from Rachel. Martha, your hand was up too. I saw it. You could give your answer. If it's the same, you can abstain.
Thank you. I also agree with AFib. Just the fact that it is sort of irregular when you look at the rhythm strip. There is where you miss some beats, but then the pattern is really irregular. So you have like 4s, and then you get to 5s, and then to a 6, and then it's really disorganized a bit.
All right, thank you. As I call back Jimmy, there is a poll that is running, so please feel free to fill out that poll. In the interim, Jimmy, you're welcome to continue. Yes, Jimmy.
Yes, thank you for those that have bothered to take us through the EKG interpretation. Yes, so the EKG actually showed us what we have been able to see. So I'm going to continue with the rest. So unfortunately, I wasn't able to secure the real picture of the CT scan, but this was the finding that we got out of this CT scan. It was reported that he had multiple intraaxial hypodense lesions in the frontal and parietal lobes, and it was more on the left. And there was also associated loss of gray-white matter differentiation and the cerebral sulci. There were no calcification, and in general, the findings were more of bilateral multifocal frontal parietal cortical and subcortical chronic ischemic infarcts with cystic gliosis. That was derived from what was seen. And he also had in the territories of the middle cerebral artery bilaterally, all these were seen. And they also noted that the patient had already grade 3 brain atrophy. So at this point, maybe I will invite back our expert to give us his thoughts about this patient. What sorts of differentials are we thinking about, and what would your management look like?
Thank you very much, Jimmy. Maybe I'll weigh in a little bit on what you've presented so far, and then maybe you can ask the group for what they think the diagnosis is at this point in time, and then I can jump in a little later. So I agree with those that thought that ECG was atrial fibrillation. I can see why some people thought atrial flutter, because on some of those leads, you have what looks like a flutter waves, but when you look at the rhythm strip, which gives you an uninterrupted view for over 10 seconds, then you have a very good, you start to appreciate that there are no P waves. As just a pointer, the best places to look for P waves is lead V1 and lead 2. So if you can't quite make them out there, then likely they're not there. And I know we usually say that, when you have AFib, you don't have discernible P waves, but once in a while you might have what looks like P waves. Be careful when the heart rate is quite high, as it is in this 67-year-old male. One of the things that can happen is that you can mistake the T waves for P waves, and you like, for example, if you look in lead V4, those are clearly T waves, but you might think they are P waves. But I think this is atrial flutter. So now, and of course, once we have atrial flutter, then you think about what are the kind of complications a patient. Number one is what kind of conditions, cardiac conditions, would predispose a patient to atrial flutter. I think one of the main common ones is when you have anatomical changes in your heart, and this is commonly a dilated left atrium, either left ventricular hypertrophy with mitral regurgitation or incompetence. It's a bit surprising that obviously that when the heart was auscultated, there were no murmurs that were noted. And the brain CT tells us a few interesting things that we can tie up with the ECG findings and the presentation of palpitations by this patient. And I would like to throw this back to the group to tell us, okay, from the CT report, unfortunately we can't see the images, but from the report on the CT and the atrial fibrillation that we've discussed, what do we think is going on in this particular patient?
Sorry, Dr. Bagonza, I think you went back and forth at some point. You said it's atrial flutter, and then at the end you said it's AFib. I don't know if it was a lapse of the tongue, so I'm not so sure. So like, what you learned?
Okay, let me just make that clear. I said I think it's atrial fibrillation, but I can understand why someone would think it is atrial flutter, but it is atrial fibrillation. And I mentioned that there are some leads there when you look at the when you look at the baseline of the ECG tracing, it looks like they are flutter waves, but they're not really flutter waves. So an example now that they've projected it, if you look, let me see, if you went and looked at, it's actually on the rhythm strip towards the, I don't know. So if you look at V3 and you look directly below at lead 2, that section of lead 2 that is beneath V3, there's a bit of undulation on the baseline of the. Move the cursor to the, I don't know, this would be to my right. Just move along the along the lead 2. So just directly beneath V3.
Okay.
Directly beneath V3, yes. So there's a section there where the RR interval is a bit long, there where the cursor is. So when you see that undulation, you might think this patient has atrial flutter, but that is not sustained. It's not anywhere else. And there are areas where you can clearly see nothing. So that can throw you off and you think this might be atrial flutter, but I think that this is atrial fibrillation. Commonly, atrial flutter is regular, but sometimes if you have atrial flutter with variable block, then you can it can be irregular. But this is AFib. And my question is, now knowing that this is AFib and the CT scan findings, what do we think is going on with this particular patient? What do we think has happened to them?
Patient is having an AFib with embothrombotic events.
Okay, hands up. I see Martha as well. Martha, what do you think?
I thought probably this patient, due to the atrial fibrillation, there is usually sort of poor contractility. Actually, there is sort of poor contractility, so it leads to stagnation. I don't know whether he took something to trigger the palpitations that could increase the force of contractility, which obstructed a vessel and then caused an ischemic stroke that we see on the CT. I submit.
All right, and I also just walk through the chart. Most people, so Pascal says it's embolic ischemic stroke. Bernard says chronic AFib with formation of an emboli. Cerebrovascular accident, ischemic stroke. So most of the chat members are saying ischemic stroke. Back to you, the experts. So Dr. Kenneth.
Yeah, exactly. Excellent thoughts. I was actually just going through the chat as well. So I agree that this patient was having has a cardioembolic CVA. And obviously from some of the changes that we see, for example, this cystic gliosis, this normally means that you've had reorganization. So you had an ischemic portion of your brain, and then it sort of undergoes reorganization, and then you get this gliosis. So this means that this particular patient did not, in fact, adjust this presentation. They've been throwing off emboli for a prolonged period of time. And commonly what happens is that patients like these who have atrial fibrillation, you can have atrial fibrillation, but with a normal ventricular rate. So that would be AFib with a normal ventricular response. So this patient would have a normal heart rate, and sometimes they may not be able to perceive, especially if they've been in AFib for a while, they may not be able to perceive the fact that they have an abnormal heartbeat or an increased heartbeat. But it is only when you have AFib and now your AV node starts allowing a lot more of those fibrillation waves to go through to the ventricles, that's when now your heart rate significantly increases, and then you're made more aware of it. But even when you have slow ventricular response to AFib, you still have the propensity to throw off small thrombi. And like Martha described, I think it was Martha, that, you know, because you have AFib and your heart is not squeezing concentrically, your blood stagnates, especially in the atria, and then you form clots in the atria, and then these clots will break off a small piece at a time, and this is what is thrown off, and it will go to the brain, it will go to the kidneys, sometimes it will go to the lower limbs. So sometimes these patients will present with thrombi in, for example, the femoral arteries, and they'll present with ischemic lower limb pain. Some of them will present with, if it's a thrombi to the kidney, they might present with lumbar pain. If the thrombi goes to the mesentery, then they can present with diffuse abdominal pain that doesn't respond very well to analgesia. So essentially, they can throw a clot anywhere there is an artery, and that is essentially everywhere. But this guy's brain clearly has been insulted over a long period of time. And the question for you as a clinician would be, why have they had an altered level of consciousness this time? They've obviously have multiple infarcts, but why are they presenting with a reduced level of consciousness this time? And important to remember that just having an infarct in your brain does not always mean that you're going to have an altered level of consciousness. You might present with neurological deficits, but it's rare that you'll be altered because unless your whole brain, both hemispheres, both cerebral hemispheres are ischemic, your level of consciousness will remain intact. The other areas, the other particular structure that would be, if it had an infarct that would cause you to have a reduced level of consciousness, is the reticular activating system, which comes from the from your thalamic nuclei and then goes up to the cerebral hemispheres, because this is what is responsible for arousal. So if you throw off clots and then they went to the blood supply that supplies this reticular activating system, then we can see how you would present with an altered level of consciousness. I see somebody asking here, was he taking his rivaroxaban? But I would imagine that this rivaroxaban was only provided during the admission in Mulago. I don't think this is medication the patient was taking. Yeah, with those comments, I'll give it back to you, Jimmy.
Thank you so much, Dr. Kenneth, for those very critical thoughts about this particular patient, also giving us our perspective on now what could have caused the pathologies that this patient is presenting with. I think that's very helpful. In the emergency department, I think Dr. Kenneth has already given us like what sort of differentials we are thinking about. One is atrial fibrillation that everyone seems to agree with. Two is heart failure. Three is we also thought that the patient actually had that aspirational pneumonia. That was explaining the rhonchi that we were, and also the shortness of breath that he presented with. So in the ED, we opted to consult with the cardiologist and also the pulmonologist. We continued the NGT feeds while maintaining the head of bed at least 30 degrees. We started him on amoxiclav, hydrocortisone, salbutamol nebulization, which was going on. Then was also given bisoprolol for rate control. He was put on oxygen therapy. And the aim of the oxygen therapy was to keep his SpO2 above 94, between 94 to 98 or 99. And then also, like I said, echo was requested, but we were not yet able to do it. We also requested for CTPA based on the fact that he had elevated D dimers. We also requested for RCT, which was, RCT was done and it turned out to be seronegative, like I reported already earlier, and it was transferred to 4A. So I would love to still pick Dr. Kenneth's thoughts on how we could have disposed this patient. Plans on how to dispose, were the consults necessary, and were, do you think that maybe there were some other specialties that needed to be consulted about this patient?
Great. So before I jump in, I'll throw it to the group. Any thoughts on the management? Are there things that you would have done differently? Or some extra things that you might have done, or some things that you would not have done? It would be nice to hear from the rest of the group before I chime in.
So I'll give an opportunity to one participant as we are racing out of time. And that will just be limited to 1 minute. So Sekuku Linda, go ahead, please. You're unmuted. Okay, seems Linda was just unmuting for fun. Onama John says he would consult the neurologist as well. Role of salbutamol. So really, I was one of the people who were thrown off initially because
Daniel, your network is breaking up. We can't hear you very well.
Yeah, I think I can't hear him as well.
CA to confuse the team, the expert meet talking about it.
Daniel, we missed your submissions. You had the line was not clear.
All right, in the interest of time, Dr. Kenneth, would you maybe proceed and so we can.
All right, no worries. So I'll jump in. I was just looking through the chat. I think Jennifer Tesha did a good job just walking us through the ECG. I see somebody was asking, did this patient have an increased JVP? Yes, they did. Isaac Guma. And then somebody gave us a breakdown of what their differentials would be. So a few thoughts that some questions, some extra questions I would have wanted to know, for example, because now we know that this patient has a cardioembolic CVA, and it's not a new one, it's been happening over time. And of course, the question is this CVA what is causing their reduced level of consciousness? So obviously on the CT, I would want to see, are there infarcts in the area of the thalamic tracts? Then the other important thing to know is outside of the stroke, you have to keep your list of differentials broad. There are so many other things in this patient that can cause a reduced level of consciousness. Number one, we've talked about potentially hypoxia, and I see that they treated with 10 liters of oxygen. So obviously this guy was probably quite hypoxic to require 10 liters of oxygen. The other thing I might have done in the assessment was to find out if this patient has features of hypoperfusion. So the presentation of the findings in the cardiovascular assessment were that The patient had a raised heart rate. We've known from the ECG that it was irregular, so AFib. They also had a raised JVP, so obviously we think that they have congestive heart failure, and this might be contributing to the chest findings that we have. But the thing that we haven't determined is whether they had features of hypoperfusion. And blood pressure alone, which Jimmy told us was normal, is not enough for us to say if the patient has a normal blood pressure, then they are perfusing very well, okay? Remember, it is important that when you're hypotensive or when you're not perfusing very well, your sympathetic system kicks in, you have peripheral vasoconstriction so that you raise your blood pressure. But these peripheries will be poorly perfused. So the assessment for perfusion would be looking at, number one, urine output. Number two would be looking at, for example, this patient who has a nasogastric tube, we would be looking at GIT absorption. If they have poor absorption, then we are concerned about the potential of hypoperfusion to the GIT. The other one, which is quick to see, would be an assessment of the periphery. So are the extremities cold? Or are they warm? What is the capillary refill? And that would give us a small idea on whether the patient is hypoperfused. And if they're hypoperfused, then we know, okay, this patient they have atrial fibrillation with cardiogenic shock, which is compensated, okay? And some of the extra investigations I might request for, and these may not be available everywhere, I'd probably get the patient's arterial venous blood gas, and I'd be interested in their serum, lactate as a marker for hypoperfusion. But it's a bit controversial on how to use this lactate as a marker for hypoperfusion, but it's an excellent tool to use if you have it available. And then, of course, why are we using, why are we nebulizing? Maybe it's probably because of the rhonchi. And for what it's worth, well, you might try and nebulize and see if this helps the patient's pulmonary function. I agree with inviting a neurologist on board. Cardiology is definitely very, very, very important. And if you're able to do a point of care cardiac ultrasound in your setting, it might be nice to look there. You may not do a full echo, but at least you can look within the chambers and look for thrombi within the chambers. And I suspect that you'll probably find a thrombus somewhere in the left atrium. Importantly, in the management that we did not cover is obviously number one, nutrition. The other things I like to call them housekeeping. So we must manage the airway. So if the airway is compromised, we either use airway opening adjuncts, for example, an oropharyngeal airway if the patient can tolerate it, or a nasopharyngeal airway if the patient can tolerate it. In some centers, they will even make the patient NPO, so it will be nil per os, and they might give them parenteral nutrition until they are sure that the risk of aspiration is significantly low. The other important thing that I would add to that management is anticoagulation. And in the acute setting, it is not reasonable. I don't think it's a great idea to use oral anticoagulants like rivaroxaban. These ones would usually give the patients at discharge. In the acute setting, you use injectable anticoagulants. So if the patient doesn't have end-stage renal disease or any contraindications to drugs like enoxaparin, then I'd give them enoxaparin. And I'd probably be giving them treatment dose enoxaparin. So this would be about 1 milligram per kilogram per day. And if they have contraindications to using enoxaparin, I would then consider giving them an infusion of heparin. So if a patient has end-stage renal disease, then you can't use enoxaparin. So you might use unfractionated heparin as an infusion. It's very short acting, and that's why we give it as an infusion. So that makes it a bit difficult. But usually for enoxaparin, this you normally give subcutaneously, usually twice a day. And of course, I would consult cardiology just for us to rate control them. So actually, I would try and get them out of the AFib. But one of the difficulties about getting people out of AFib is that if the AFib is triggered by structural abnormalities, it's quite difficult to get them out of the AFib. And normally then we change our goals of care to just making sure that we rate control them, because obviously this guy is beating 150 beats per minute for a patient who's 67 years old is too high. and that might be compromising venous return, okay, and ventricular filling, and this might even be worsening the hypoperfusion. So this is a patient in whom, if you bring that heart rate down, then they'll have better hemodynamic performance. And obviously, disposition would be admit them. In most, if you're in a well-resourced place, this is a patient you'd probably admit to the HDU at the very least. But I know in most of our places, we don't have HDUs, but wherever you admit them, you need to know that this is one of your sickest patients, and you need to keep a close eye on them. There will not be much that you will do for the impacts that have already happened, but you can prevent secondary insults. Thank you very much.
Dr. Wagonza, there's one quick question for you, and just flagging that we're really out of time. The question, is there a role for synchronized cardioversion, given that the patient is on?
Okay, so excellent question. Role for synchronized cardioversion. So there are certain indications for synchronized cardioversion. Obviously, you need to first ask yourself, is this patient stable or unstable? And if you think they're unstable, then there might be a role for synchronized cardioversion. Now, we recommend, most times if you're going to cardiovert these patients, it is best that you give them, you sort of provide them anticoagulation for at least 48 hours before you attempt to cardiovert them, because the risk is that switching them from AFib to a normal rhythm can sort of trigger breaking off of further clots and causing infarcts. But if you have a patient who's hemodynamic, this guy was hemodynamically compensated. But if he was decompensating and is rapidly deteriorating, then you are between a rock and a hard place. So I'd probably consider cardioverting them. But I must caution you that cardioverting these guys can be quite a painful experience, and not painful for the patient, but painful for you, the clinician who's cardioverting, because it can be very, their AFib can be very, very stubborn. It will require large amounts of energy, and sometimes you'll cardiovert them, and then they'll transiently go back into a sinus rhythm before they revert to atrial fibrillation. So it can be quite difficult to cardiovert them electrically. So the option for me, if they're not hemodynamically unstable, would be to sort of gently cardiovert them, but first of all, start anticoagulation and then look at agents that can gently cardiovert them. So if they're hemodynamically unstable, I might use some DIG, but then this patient has renal issues, so there are some cautions about using DIG, but red control is good enough. And then there's also a role for amiodarone. Turns out amiodarone is a drug that works for almost all sorts of tachyarrhythmias. So you can chemically cardiovert them with medications.
Thanks, Dr. Wagonza. It looks like we are literally at the top of the hour. Dr. Tiela, I don't know if you want to pick it up and give
thank
it.
you. I think just really a conclusion. I think we can all realize that sometimes patients might not present to us in black and white, that you're just going to look at them and you're able to figure out the diagnosis, or even be able to know exactly what to do for them. Like for this particular patient walking into the referring center and just complaining of palpitation, and ends up with altered levels of consciousness. And then we also get to realize in a CT scan that actually this guy has been throwing, it's been having like thromboembolic events for a very long time. And then just tells us that we need to really cast our nets wide if we are going to be able to reach to conclusion of what exactly could be happening in these patients. I would invite us to read about atrial fibrillation. I think then read about the management presentation. Then I think that is it from me because of the time. Thank you. I will invite Daniel.
Yeah, Dr. Linga, are you back? It looks like Dr. Linga's signal. Oh, you're back. Perfect. Go on.
All right. Thank you very much, Jim. And all came in with palpitations. We now know that it's AFib, and this is one of the common presentations that will occur to us in the elderly and patients with hypertension. The list can be so long. Dr. Kenneth, under 1 minute, could you give us the pulse and AFib? Just 5 take-homes.
Okay, Daniel, I
Same.
think your network is not very clear, but I had the last part. Pulse.
Yeah,
So,
pulse and pitfall. Take homes, yes.
in 1 minute, let me set my clock. Okay, great. So thank you very much, first of all, for the team that put together this case. I think it's a very interesting case. It's always important to remember that atrial fibrillation is not just the cause of, I don't think it is the cause of this guy's problems, not all of them at least. It might be a trigger, but there are other underlying issues that we need to think about, things like aspiration pneumonia that might have happened to this patient. So remember, when patients present to the emergency department, don't be pressured to find a diagnosis. In the emergency department, sometimes you need to be comfortable with managing the patient even without a diagnosis. And what you're really working with are problems. So if it's hypoglycemia, you correct it. If they're hypoxic, you manage that. If they have hemodynamic instability, you try and sort that out. And maybe for atrial fibrillation, not all patients with AFib present to the ED. A lot of them are outpatients. They are out and about running their lives, I'm sure, like this guy was. But it is the decompensated ones that will present to the emergency unit. And remember that the goals of care are, number one, trying to find what the trigger for the atrial fib is. So one, we can look at metabolic triggers, so thyroid problems, renal problems, problems that have to do with catecholamines, problems that have to do with the use of illicit drugs, especially if the patients are a bit younger. And then the other thing is, what are the complications of this patient having AFib? Are they in heart failure because of AFib? Are they formed a thrombus in their cardiac chambers because of AFib, and we need to take care of this? What is their risk score for developing a stroke? And somebody put a CHADS 2 VASC score there, so you can risk stratify them and then have a treatment plan for them. Most of them will be managed as outpatients, but when they present to the ED with complications, then we need to manage their complications. And when you're treating the AFib itself, you decide, am I rate controlling? That means I'm not getting rid of the AFib, but I'm slowing down the ventricular response, or am I converting them to a normal rhythm? And whether you choose rate control or rhythm control largely depends on some factors that you would assess in the patient, but also what you have available to you. And remember that try and get a multidisciplinary team involved as early as possible. And I hope with that, we've given you a small starter pack on how to think about patients when they present to the ED. Thank you.
Great. Thank you very much, Dr. Kenneth. And there is a poll on your screen. You could just fill that out quickly. And we want to thank you for sparing your 1 hour and 4 minutes now for gladly listening out to this wonderful presentation. A great thanks to the team that put this together. I'll definitely make mention of your names in due course, but Dr. Bonnie, Dr. Andrew, Jimmy, so glad, and everyone behind the scenes for making this work out. Let's continue having this. With your poll, we shall give you the best timings and etc. But this is the start of something great to come. And I just want a comment from Bonnie before I say good night to everyone. Hoping we are feeling it out. Don't log out before you complete.
No, thank you all. I think this gives us a test dose of what is yet to come. And special thanks to FUMSA, to CareU, Master Makere, C team for working together to get this started. And we hope that it will be a platform for shared learning. Thank you.
All right, thank you very much. Continue filling out the poll. Otherwise, as you're done, allow me wish you all a lovely night, and let's manage the AFib patient.
Danny, could we take a screenshot if that's okay?
Guys, stick around. You're living in a tremendous speed. We are going to take a screenshot. So turn on your screens. Please have your t-shirt on or your shirt or your dress on and smile along. Andrew, hope you're doing the needful. You can shout out case-based learning as you're smiling.
Case-based learning.
Thank you.
Thanks. Thank you, Dr. Kenneth.
Jimmy, share the slides with the team. I'm seeing people asking for it.
All right, I'll
Kezika
do
Morin
that.
did not receive the poll. The poll should be on your screen. Departure at leisure. Bye.
Mm. Mm. Claro.